Good evening to all who are joining. I've been asked to talk about pharmacotherapy for ticks, and so I'm going to talk about what we currently know, what the evidence base is for pharmacologic management of ticks, but give some practical advice from my own experience to maybe correct some. So what are ticks? Tics are really characterized by being stereotyped, repetitive, involuntary movements. They are sudden, they're discrete, they're non-rhythmic, and most commonly they involve the head and upper body, but tics can involve really any body part. They are stereotyped, and by that I mean each particular tic happens the same way over and over and over. I would see for an initial evaluation, never came back for treatment after that initial educational talk. Remember, tics wax and wane. They increase and decrease, and that can make the interpretation of treatment effects difficult. Very commonly, tics worsen at the beginning of the school year, and there is often pressure to initiate treatment at that time. And if treatment is initiated at the beginning of the school year, I guarantee that tics will be better in 4 to 6 weeks. But if treatment is not initiated, I guarantee that tics will be better in 4 to 6 weeks. That is part of the natural history of tic disorders in relation to the academic year. The tics almost always worsen around the beginning of the school year, and then they improve 4 to 6 weeks after the school year starts. This is another older study from James Leckman and colleagues at Yale. And what they identified is that tics follow a fractal temporal course. And so you see bouts of tics, and they cluster then, and you get into bouts of tics that cluster across days, that may cluster across weeks, that may cluster across months. So the tics are not evenly distributed across the course of the day. They're to about 2/3 of children. The good thing about the alpha-2 agonists is they can also be quite effective for ADHD symptoms. The most common side effects are sedation, orthostatic hypotension, bradycardia, dizziness, and depression. Sometimes it just makes children so groggy that they fall asleep in school, although the sedation does abate with time. Guanfacine is much less sedating than clonidine. Guanfacine has a longer half-life than clonidine, but again, there are parts of the world where guanfacine is not available commercially. In children with a family history of long QT or who are on combination therapy, the QTC should be monitored or should be measured before starting the alpha-2 agonist, should be monitored periodically. For children who are on monotherapy, I don't check an EEG unless there is a family history of long QT or unexplained syncope.
And with clonidine, what's the recommended dose that you started? Do you start very slow and low?
Yeah.
Or?
So clonidine, the main thing with clonidine is the half-life is very short. And so if you use immediate release clonidine, I usually start it at bedtime. It can help with sleep. Some small studies that have looked at TMS, but the problem with TMS is to have lingering, lasting benefit that will last more than hours to days. But I think that there is real potential there as well.
Thank you. Thanks, John.